Hello, my name is Lucy Clarke. I'm an occupational therapist, advanced clinical practitioner. I am now the East Area Clinical Lead Occupational Therapist for Mental Health within the Betsi Cadwaladr University Health Board. Today I'm going to share with you a detailed service evaluation of a newly established occupational therapy group intervention, the Skills for Better Living course. This is for patients presenting to a primary care practice with common mental health disorders. I used skills learnt during master's level study whilst working as an occupational therapist within a flagship surgery piloting a multidisciplinary team approach to general practice. The novel occupational therapy role within primary care is to support self-management of chronic conditions across the adult population. Occupational therapists can enable people to change their lifestyle and improve their ability to carry out daily self-care, productivity and leisure activities which improve health and well-being. From the outset, the majority of referrals to occupational therapy were for people in mental distress, often secondary to the person's circumstances or comorbid with other chronic conditions and impacting on daily life, exacerbating other symptoms. An SBAR established numerous drivers, including the prevalence of comorbid mental and physical health issues, the need for self-management support alongside early intervention and prevention, and the impact mental health issues have on sickness in the workplace, representing costs to both industry and services. The occupational therapy team established good liaison with Tier 1 mental health services to refer on anyone with significant mental health issues or high risk, avoiding duplication. We used prudent principles harnessing local community assets, such as the National Exercise Referral Scheme, MIND or CRUISE, to signpost and socially prescribe for those with mild difficulties. However, the SBAR revealed a clear gap in service provision for a population of people who would benefit from tailored intervention to support mental well-being, by focusing on personal, occupational goals which would enhance self-management. I led the development of a community group-based intervention and its associated resources, the Skills for Better Living course. The occupational therapy 5-week course was based around the 5 ways to well-being. We supported attendees to set SMART goals focused on specific, self-selected occupations that would improve their daily living. Activity scheduling, problem solving and peer support were harnessed to overcome barriers to coping with daily life. Social prescribing was used to connect people with their local and relevant community assets. An understanding of anxiety and depression was fostered through patient education. Specific evidence-based self-management skills were taught, such as breathing, relaxation and mindfulness techniques, alongside cognitive behavioural therapies. Skills were embedded into daily routine and used as tools to help participants to take steps towards their own goals. What follows is a retrospective evaluation of this service. We collated results from patients who attended the first 5 courses, counting only those who attended at least 2 of 5 sessions, a total of 30 people. For quantitative evaluation, we used 4 standardised pre- and post measures. The Patient Health Questionnaire 9 and Generalised Anxiety Disorder 7 are both routinely used in primary care as per NICE guidelines to assess mood and anxiety. The Work and Social Adjustment Scale assesses the impact of symptoms on aspects of daily life and is a measure suitable for occupational therapists. In addition, we used the Canadian Occupational Performance Measure, a well-recognised standardised instrument for occupational therapists. This measured clients' perceptions of changes in their performance of their goals alongside changes in their satisfaction with their performance. Qualitative measures came from a review of contact notes from each session, capturing comments recorded by the occupational therapist on any changes in the patient's daily function or their account of using skills and techniques learnt. In addition, comments from several different available feedback forms were collated. These included course-specific evaluation forms, surgery feedback forms, and patient experience forms, all anonymous. We can see that attendance at the group was good for the majority of the attendees, with 73% of people attending 4 or 5 of the 5 sessions. The majority of participants were over 50 years of age and 87% were women. This is in line with findings about the demographics of people with common mental disorders by the Mental Health Foundation. Here we have the quantitative outcomes from the service evaluation. Before and after scores for at least one of the 4 measures were collated for a total of 20 people who attended the course. That's 66%. We can see improvements in the mean scores for each of these measures. 90% of those whose scores were collated demonstrated improvement in at least one of the measures. 70% of the 20 attendees who submitted before and after scores had an improvement across all measures submitted. Only 2 people's scores stayed the same or worsened. However, 10 people did not complete after course measures. For qualitative outcomes, the occupational therapy notes from the electronic record for each of the 30 attendees were reviewed, including the contact notes for each group attendance and follow-up at discharge. Any comments made in the contact notes regarding patient progress were grouped into categories, and these 4 included an increased ability to set goals, improvement in coping with and managing symptoms, increased participation in daily occupations, and better relationships. 28 of the 30 participants' electronic records noted positive outcomes. This slide shows more detail of the comments grouped into categories. 14 patient records recorded an increase in people being able to set themselves realistic and achievable goals, plan their time, solve problems towards goal achievement. 21 patient records identified improvements in being able to self-manage symptoms, such as being able to step back and calm, cope with difficult situations, and feel more confident in interactions. 21 patient records identified increased participation in occupations such as being able to go out and socialise, engage with hobbies, return to work, manage daily routines, or become more physically active. 9 patient records demonstrated an improvement in personal relationships and confidence to be assertive within them. The comments from 17 patient feedback and evaluation forms were analysed, and 5 recurring themes emerged. These are paraphrased as: it was a helpful course, the group is supportive, learning skills helps me cope, it's important to look after me, working towards my goals is key. In summary, this occupational therapy intervention increased the ability of participants to function in their daily life and improved the mental health and well-being of people with common mental health disorders in a primary care setting. Obviously, there are limitations from conducting a retrospective service evaluation as opposed to empirical research. A service evaluation can only access that information which is a natural and routine part of clinical practice. Consequently, data collection is affected by the fluctuating consistency and detail of what is recorded in the patient record, and how thoroughly outcome measures and feedback forms are collected in live and real-time service delivery. There were several staff and students from different experience and backgrounds delivering the course. This, of course, affects consistency with recording information. Unfortunately, not all participants attended the end or outcome review session or returned post-intervention scores and evaluation forms sent out in the post. And finally, there is evaluator bias, which is not mitigated against in the methodology, as I created, delivered, and evaluated the course. However, this approach embeds service evaluation into routine practice, demonstrating efficacy of interventions without the cost and burden of empirical research. It can be considered as a stepping stone towards more robust research and hones the practitioner's ability in applying research skills learnt in master's level training. Thank you for listening. Please post any questions.